Hello, this is group 3, and our disease was hereditary hyperekplexia, also known as the startle disease. First described in 1958 by Kirstein and Silverskold, a family was described as experiencing drop seizures. Then later in 1962, genetic analysis within a large Dutch family pedigree found a mutation within the GLRA1 gene. The GLRA1 gene accounts for about 80% of the cases of hyperekplexia. Hyperekplexia is a rare hereditary neurological disorder. In most cases, it is an autosomal dominant trait, but has been reported as autosomal recessive and X-linked. In most cases, the onset is in utero or at birth, but some occur in adolescence or adulthood. Other genes found at a later time are GLRB, SLC6A5, GPHN, and ARHGEF9. Although GLARA1 is one of the more common underlying biological factors, there's variation in expression. Two brothers within the same family can have the same mutation but different phenotypic expressions. To try and better understand these differential factors and mechanisms of action, researchers are looking at the disease on a molecular level. In the video, we're going to talk about hyperekplexia caused by mutations in GLRA1. When there is a mutation in GLRA1, this impacts the glycine receptor. This receptor is a cis-loop ligand-gated ion channel for chloride ions, which is located on the postsynaptic membrane. It is a pentameric receptor, meaning that there are 5 subunits that surround the central ion pore. And you can see this in photo A. There are 5 subunits, alpha and beta subunits, making up the glycine receptor. And in picture B, it shows a view from above looking down on the glycine receptor. The glycine receptor is mainly in charge of mediating postsynaptic inhibition in the central nervous system. Before I talk about hyperekplexia, I'm first going to talk about what happens when glycine binds to the glycine receptor. Glycine is the ligand that binds to this receptor, which leads to a conformational change to an open state. When the receptor is in this open state, the chloride ions are able to flow into the postsynaptic cell, causing intracellular hyperpolarization as the ions are negatively charged. This hyperpolarization prevents action potential from being reached, thus inhibiting signaling and diminishing action of nerve cells in the brain and spinal cord. GLRA1 codes for the alpha-1 subunit of the glycine receptor, and when it's mutated, the glycine can't bind to the receptor anymore, so there's no conformational change, and this means that the chloride ions are unable to flow into the postsynaptic neuron. There is no hyperpolarization without the chloride ions, and action potential continues to be reached. This causes nerves to react too easily and excessively to stimuli.
Hyperekplexia is often misdiagnosed as a seizure disorder. However, it is now characterized by episodic and generalized stiffness after birth, which subsides within the first few years of life. Those who suffer from hyperekplexia also experience increased likelihood for apnea attacks, delayed speech acquisition, and intellectual disability. Here you will see a picture of a normal mouse on top and a mouse suffering from stiffness on the bottom. Other characteristics include excessive startle reflexes in the form of forceful eye closing, rising bent arms above head, and flexion of trunk and other joints. This is persistent throughout life, which can result in stiffness that may lead to injurious falls. Here you can see the sequence of movements during a startle reflex. As you can see, it is more exaggerated than the norm. Physiological effects are often dependent on the mutation. For example, developmental delays and sleep apnea attacks are more common in recessive hyperekplexia, 51% as compared to 10% dominant hyperekplexia. In addition, hyperekplexia due to GLRB or SLC6A5 mutations are twice as likely to experience developmental delays. In another example, all cases of hyperekplexia due to GLRB mutation results in hypertonia. However, that is not true for other forms. Next, you will see a video demonstrating some of the symptoms of hyperekplexia.
This shows the normal gait of someone with hyperekplexia without treatment. There is stiffness in the limbs and an expressionless face. As shown in the video, there is a cautious walking gait and the patient is easily startled.
Currently, no cure exists for hyperekplexia, but treatments exist which aim to mitigate the symptoms. First, drug therapy is most commonly used to diminish startle reflexes and the anxiety that may accompany symptoms. This drug, most often prescribed, is clonazepam, an anti-anxiety and antispastic drug. Clonazepam is a sedative drug which acts as a GABA receptor agonist. This potentiated inhibitory effect compensates for the lack of glycine-gated chloride channel functioning. It is known to help with hypotonia and apneic, meaning a temporary halt in the flow of breathing, symptoms, but is not effective in stiffness. Besides the prescription of anti-anxiety and antispastic drugs, the only other treatment used to help symptoms include physical and occupational therapy. These resources can help patients gain access to devices such as strollers, walkers, seating devices, and others which are intended to improve the patient's quality of life. Additionally, breathing or heart rate monitors are sometimes suggested for parents with small children with hyperekplexia in the case of significant breathing challenges. Lastly, cognitive behavioral therapy can be utilized to reduce anxiety levels as well.
When the patient is using the wheelchair as a walking aid, their gait has visibly improved. After the patient has received clonazepam, their gait has improved and they do not need assistance with any devices.
The current treatment of hyperekplexia can only manage some of the symptoms of the disease, but are not able to cure the condition. While the drugs commonly used to treat hyperekplexia are effective in managing most symptoms, they do not effectively manage the stiffness associated with the condition. Long-term treatments with clonazepam, similar drugs, can reduce the average stiffness experienced during an attack, but no currently approved drug is able to reduce or eliminate the stiffness experienced while an attack is happening. Additionally, many of the life-improving medical devices, such as walkers and breathing monitors, can be expensive for patients and financially limits patients from the best possible treatment. The future of hyperekplexia treatment is mostly unknown. Currently, there are no clinical trials for hyperekplexia drugs. As the condition is rare, there is not a lot of motivation or funding to study or develop treatments for the disease, which severely limits the possibilities of future treatments or even cures. Most current studies are instead looking into identifying current drugs that could be used or modified to be used to treat symptoms of this condition. One particularly promising outcome of these trials is the success of using low doses of the benzodiazepine clobazam to treat the stiffness associated with this disorder in infants, which is shown to be successful in a limited trial of 2 infants.
A summary of what you should know is that hereditary hyperplexia is most commonly caused by a mutated GLRA1, which impacts the glycine receptor, and there is a lack of inhibition, causing nerves to react very easily and very excessively. Some effects would be limb stiffness, forceful eye closing, and an altered gait as a form of subconscious self-protection. And while there aren't any cures for hereditary hyperplexia, there are a number of treatments that can help the patient, such as walking aids, medication, and more. Thank you for listening.